Welcome, everybody, to our August Lunch and Learn. We are delighted to welcome Dr. Mikhail Kogan to discuss the future of healthcare for older adults, a personalized, whole-person, integrative, and functional approach. Dr. Kogan is a leader in the newly established field of integrative geriatrics. Dr. Kogan is the medical director of the George Washington Center for Integrative Medicine and associate director of the Geriatrics Fellowship Program. He practices geriatric and integrative medicine in a variety of settings at the George Washington Hospital, at the George Washington Center for Integrative Medicine, as well as serving patients in home visits. Born in Moscow in the former Soviet Union, Dr. Kogan immigrated with his family in his teens, first to Israel, then to the United States, where he obtained his medical degree from the Drexel University College of Medicine in Philadelphia, residency in internal medicine at Montefiore Medical Center in New York City, and a fellowship in geriatric medicine at the GW University Medical Center in DC. In addition to his training in conventional Western medicine, Dr. Kogan has pursued several other healing arts and practices that have shaped his approach to patient care. Weaving these tools into the fabric of his medical practice enables Dr. Kogan to provide innovative and effective treatments to his patients with minimal use of invasive procedures or heavy reliance on medications, and to understand the importance of self-exploration, awareness, and positive lifestyle changes as essential milestones towards better health. In 2017, Dr. Kogan's Integrative Geriatric textbook was published by Oxford University Press, and this book is part of the Andrew Weil series on integrative medicine. It is the first definitive textbook in the field of integrative geriatrics and best suited for patients and practitioners who want to have complete reference book on how to manage several clinical conditions in older adults. I could go on and on with Dr. Kogan's many attributes and experiences and credentials. We will have some books for sale here, and at this point, I would like to introduce Dr. Kogan. We're very grateful to have you.
So I understand that you get this great food every time, right? All right. So before I actually even get to the talk, well, first of all, I'm just shocked the borscht was so good. So let's put a round of applause for the cooks and for everybody who made all this happen. So by the way, how many of you have known that the beets is one of the most powerful superfoods that you can eat? Good, right? Do you know what it actually does? So beets have a molecule that rapidly upregulates and stimulates production of nitric oxide. And nitric oxide is a very important molecule. It helps us to dilate our periphery. So it drops the blood pressure, makes the heart work easier. Yeah, better? Perfect, yeah. So it helps to decrease blood pressure. It helps to dilate peripheral vasculature so your heart works better. And it's actually a very powerful performance drug. Every elite athlete in the country take beets. They don't eat borscht, I think. They take capsules, so the beets concentrates. But it's a standard, since I see a lot of elite athletes in my practice, and you'll see in a second why that is the case, and everybody's on this stuff. It literally it increases the speed of your performance, particularly for cardio, for like long distance runners, for bikers, for whoever. Yeah. And then what is the verdict on tea and coffee? And good. Yes. So, if you're very sensitive to caffeine, do decaf, but make sure you get decaf that is organic. Coffee has to be organic. It's really important, because otherwise it's heavily contaminated always. And so you have to get organic coffee, and you have to get it. If it's decaffeinated, make sure it's naturally decaffeinated. There are processes where they use very harsh chemicals to decaffeinate coffee. You don't want that. Okay, so one other thing I'll say as an introduction, the topic of medical cannabis is going to come up halfway through the talk. You'll see I put it in a particular area. And it's still a shock to me that now I'm considered, quote unquote, an expert for medical cannabis in older adults, because I grew up in a culture that telling you something like this. You have one puff of this stuff and that's it. And you're prostitution killer and you're a premature death and that's it. And so I'm just always like amazed that now I advocate for use, and I'll talk about that more. So a couple of disclosures, the books that are here for sale, a lot of the information that I'm going to be talking comes from these books, and of course I collect royalties. And also a lot of the things that I will talk about in the presentation is what I do in clinical practice. And I'm a full-time associate professor of medicine at GW, but I also run my own practice, which actually is a separate business, so I have to disclose that. Sounds okay? Everybody can hear? Okay. So this is from my book that I wrote, and when I think the part of me always wanted to be close to older adults. All my grandparents for both sides died when I was very little, so I really don't remember any of them except for some kind of occasional, a little bit of memories. But it's really, I always feel like I've been feeling the void that first 15 years of my life was not met. But it's really essential, I think, that we don't think that aging is associated with just the decline and sort of disappearance from society, right? In fact, if you look around the world, especially in these areas called blue zones, where people tend to live a lot more frequent to 100 and above, the person who would reach 100 would consider be a celebrity and surrounded with all kinds of attention, and more importantly, that person was contributing to society ever increased amount of value, versus in America, it's kind of reverse, right? Once you're out of the official workforce, your contribution is declining, and I think that's very unfortunate. And whenever I can, I speak loudly about that that has to change. And in Europe, it is changing rapidly. Europe has been designing multiple different ways of not just healthy aging, but also meaningful aging, which I think to me is just as important. But this is sort of how, when I teach a lot, we have a both Geriatric Fellowship Program, which I co-direct, and also a lot of medical students. So, when they come to us and they work with us in the clinic, in a nursing home, in a hospital, that's what they see, right? They're really not seeing the vibrancy that could be. So anybody wants to take a guess how old this guy is? This is a real person from Sardinia, which is it's Italy, a little island in Italy. So you want to take a guess how old he is? He's 103 on this photo. Now, I don't know if he's still alive. This is back from 2017, probably not. But, he's 103 and he works 8-9 hours per day in the field. So if you're interested in this topic, by the way, like this sort of exceptional longevity, which I'm not going to talk much today about, I highly recommend that you read the book called Blue Zones, which is it's an anthropological book. It's really not medical book, but it was created by the project. It's called Blue Zones. And also you can just Google and go on a website at bluezones.com that describes the project, how the research into this areas occurred. And of course, Sardinia is one of those areas. Anybody knows who this is? So this is the most decorated elite athlete in the world I've ever seen. She started exercising formally at age of 75. At age of 90, she beat every existing record in the category for men and for women on the track. So she was faster than most of the men her age. And before she died in 95 or 96, I don't remember, at age of 94, she had the most medals and most records out of every human being on the planet. And if you take the coefficient conversion, she's a lot faster than Usain Bolt. If you convert the age and sex and adjust for that. So her name is Olga. She's Canadian. If you're interested in reading the whole story, it's called What Makes Olga Run. Great book. If you want to find a small detail, her entire life she ate really poorly. Like she would have oatmeal for breakfast and then some meat and potatoes for lunch and meat and potatoes for dinner. Like, and you will see this is repeatedly through the talk. I will be trying to dismantle a lot of myths because this culture particularly is all about quick fixes and a lot of myths. Like right now there's this crazy diets that are out there. And the reality is there are certain principles that are a lot simpler, a lot more intuitive. Like it should be very intuitive that the diets are completely different around the world wherever you go. And as long as you eat no processed food and you don't eat a lot of sugar and empty calories, you're going to be okay. You know, and that's like such a simple principle, and yet everybody go left and right to the extremes, and then the vegans will say that the carnivores are crazy, and the carnivores would say that the vegans are crazy. And the reality is there's all kinds of shades of gray, and everybody's right. You know, and the real simplicity here, if you look at what these people eat on the right, you know, what the people who in blue zones eat, it's all over the place. Some are vegetarian. In Loma Linda in California, Seventh-day Adventists, they don't eat any meat. You go to Sardinia and they eat meat or some kind of animal protein every day, twice a day. You go to Japan, to Okinawa, and they almost have no meat, but they have a lot of seafood. And so everything's different. And somehow we sort of presume that there's going to be a next new guru who's going to tell us how to eat right. And, you know, I think this is all commercially driven and all BS, 90% of it. And only 10% is probably the kind of the core essence that is essential. And Blue Zones actually covers that very well. And in essence, I just told you this, eat more plants, make sure that they're non-processed. If you do process your foods, it's a kind of a more natural processing, like yogurt or, you know, beets, fermented beets, for example. So things that are naturally occurring, or alcohol in small amounts. That's my motivation. That's my dad. So this is, I think 7 or 8 years ago. So 7 years ago, he was 80. He just turned, so he won Philadelphia Marathon. Well, obviously, there were only 4 of them, so that was easy. But he could actually never get to the top 2 before 80 because there's 3 professional runner guys in the 70s that are roughly his age, but then they stopped when they crossed 80. So he beat them all that year. We still run, and every year now we don't run Philadelphia Marathon. He's very particular. He's an engineer, very particular about COVID. So he's like, I'm not going to crowds. So we just run on the Philadelphia Marathon in the Penny Park, which is close to where he lives. We just run our own race together with now 3 generationals with one of my kids. Okay, so you know how we always were told that we're the best healthcare system in the country, in the world, right? So we suck. We're horrible. We're number 42. We're behind Cuba and Lebanon. In fact, Cuba has dramatically better healthcare system than us, all in all, and all of their health outcomes are significantly better than ours. So don't try to read this. This is top 30 countries. The US is not anywhere near there. But what's interesting, when you look at all these countries, they're pretty much all developed countries. That is important. So we are the only developed country in the world that's not in the top 30 healthcare outcomes in terms of life expectancy. I'm not even going to talk about other things because that's a whole separate conversation. And by the way, you would be asking correct question to say, well, but that's not because, we don't have a lot of people live longer. That's because we have such a healthcare disparities. That's not the right answer. That's only a small portion of the problem. The biggest portion of the problem, we over-medicalize the healthcare. And the core of this talk, which I hope you're going to get, is the understanding that you have to be afraid of healthcare system more than you're afraid of your illnesses. And I'm not afraid of saying that, because there are ways of handling most of the healthcare illnesses in a much safer way, okay? And if you don't believe me, let's look at the data. Before we do that, so this is what happened, right? So a rapid drop over there, right? You would think it's a COVID, but COVID only did a little blip over there. And in fact, actually, there's a rapid recovery now in other countries, but not in US. So we have lost, look at the number, it's at 76. So we have lost, we're now average life expectancy 76, right? So it's a pretty terrible. Who knows what number one country in the world is? And you will get it wrong, and that's okay, but you'll remember. Finland. I don't think they're in top 10. They're happy though. They're very happy, yeah. And they also, similar to my comrades where I grew up, they like their drinks, and probably that's why they're happy. No, actually, I don't even know where Finland is. Probably not. Yeah, probably not in top. Yeah, but no. I don't know where they stand in terms of longevity. But no, but I would never think of them as anywhere near the top. Anybody else? Japan. Okay, so Japan used to be number one for a long time. Not anymore. You'd be surprised when you hear the actual answer. It's Korea. Women in Korea getting close to 90. Life expectancy. Not the communist one. I always get those two confused. It's the South Korea, yeah. So it's not really clear why, but it's particularly women in Korea is the current record keeping in terms of longevity. But for a long time, it was Japan. And Japan is somewhere around getting close to 85 at this point. So we're almost a decade behind. But that's not a small difference, you know. So we've talked that this is opioid crisis, that's a big part, the COVID, HIV. The system keeps telling us that this is the answer. The real answer is a lot simpler. Look at this. This explains everything. So this is us on the right. At least 42% of people over 55 going to have more than 3 chronic medical conditions. Now look at the Frenchies. They smoke, they drink, they have a lot of non-monogamous sex, and look, they're 3 times healthier, right? Only 15% of people at the same age will have 3+ conditions. So it is basically based on our culture. It is not necessarily, this has nothing to do with healthcare system alone. This is the cultural aspect. We are a very unhealthy culture. And despite the fact that if you look at number of people exercising, we're number one. In terms of smoking, we're one of the last. In terms of alcohol, we're not in top 10. Okay, we're not that far behind that, but we're not top 10. Finland is like top 3, I think. You know, I'm not talking about Russia. They'll probably beat everybody, but I'm talking about developed world, right? So, and yet we do poorly. And the real reasons for that are not 100% clear, but they have more to do with a combination of factors. The natural awareness of what good food is, okay? Good food will not be considered McDonald's in rest of the world. Good food will not be considered eating on a go while you're driving some sandwich, right? So the culture of the food is different. In the US has different culture for that. The movement, right? We're sort of compulsory exercisers. Like you all heard this thing called weekend warriors, right? That's a purely American thing. You go around the world, actually there's not that much exercise. If you look at blue zones, nobody exercises. There's no such concept of exercising. They move. They move for work. They move because they just have to move. Anybody knows this little island called Ikaria? So Ikaria is a little island. It's a Greek island, but it's really close to Turkey. Tiny island used to be where they would send all the dissidents and criminals. And the Ikaria is one of the blue zones. And the reason is partially very simple. They have to be completely self-reliant. They had to grow all their foods and all their medicines. So they developed herbs. So they were growing herbs for medicine. And there was no roads and no transport. Horses could not move too rocky, too up and down. So they would walk. Like an average person would walk a half a marathon every day. 7 days a week, no breaks. So that's who we are. You know, we're supposed to do certain basic things. And yet, how did we all get here? Did anybody walk? All right. Okay, good. Now that's right. I drove. I'm sorry. So, but that's the reality. We have substituted comfort of modern living, and that's why partially we're losing a lot of our health. Societies that preserve the component of living natural, being in the elements the way they are do a lot better than us. So do we have a way out of this? I think that's really the question. And as if I didn't give you enough bad news, and I promise this will end, but this is even worse news. So if you look in terms of, that now is very relevant to all of you in the room. So if you look around what's happening in our healthcare system, this is practice as usual, myself included. I'm not any different. So if you go into healthcare system, every year, 5 million older adults are going to have adverse drug interactions or adverse drugs effects. And 42% of the adults over 65 take 5 or more medications. And there is 200% increase in polypharmacy in the last 2 decades. And that translates to this, that medical errors in the standard of care are the 3rd leading cause of death, about 250,000 of people every year. If you add to this number of severe complications, it increases this number to 1 million every year. Yeah. More than 5 medications by default. So many medications. Good question. Thank you. By the way, if you also add Alzheimer's here. Alzheimer's is not included here because people don't die directly from Alzheimer's, but they die from complications of Alzheimer's. Actually, then the whole picture is going to look a little different. But look at the amount of accidents, for example. It's tiny compared to how many accidents are caused by prescribing medications. And by the way, this is not a physician's error. Okay, this is really important. This is simply an error because you would not be able to avoid it. It just happens because this is what we do. You know, you can't really always predict what's going to happen. You can't predict interactions. You can't predict certain things. You know, we're not computers. I always lately been asked, well, artificial intelligence is going to solve all this, right? Well, I'm actually a believer. I do think there's going to be improvement here. I think the systems will improve over time, but it's not going to be quick. More importantly, I think it's going to be a period of a total chaos before we find the right approaches. So there may be some worsening. Correct. So it does not take anything non-prescribed. Yeah, there's a separate category for that. It's much smaller. Anything over the counter, the mortality is a fraction of that. Like literally, it's a few thousand people a year only. Now, if you take going to a hospital and dying as a result of being inside a facility, that adds another massive chunk, at least 100,000 people a year. But, you know, I'm putting these numbers not for that, right? I mean, theoretically, if you're doing really well living in a community, you should never end up in the hospital, well, God forbid, right? And hope for that. But this is like probably a good proportion of you in a room take at least few medications, right? So you are included in that package, so to speak, simply by the reality of this is what we do. It is not because somebody screwed up. I mean, that happens too, don't get me wrong. There's a lot of errors particularly, but just general practice in itself causes a lot of errors that theoretically could be avoided. Practically, no way. It's not, if I have a patient on, say, which is not uncommon, yeah, especially people who are like in their 90s, I sometimes get these consults where patient would have 20 medications. I'm not a computer. I can't sit there and figure out all the interactions. There's no way. Even computers, like somebody did this experiment once. They took top 1% of people who are more than on 25 medication. And they gave the interactions, side effects, interactions with nutrients, vitamins, and other things to a computer. One computer took 2 days to calculate chances of outcomes because it was that sophisticated. I mean, you're talking about billions of possible interactions, you know, plus some of them we probably don't even know. I mean, this is things we know. What about things we don't even understand or know? So that's even more complex.
Doctor, excuse me. We're going to have a question session afterwards. Okay. We have a Zoom audience, and they can't hear questions unless they have a microphone.
Perfect.
So we'll provide that later.
Okay. And I'll remember if question comes up, I'll speak the question first too. So. Okay, but they can see the slides, right? Folks on Zoom? Okay, very good. So I come up with this definition primarily based on, there's a consortium of academic health centers for integrative medicine, which has been around for a long time. Our center is part of that consortium. And so we came up with the definitions because we wanted to have something that could be easily described. And the key aspect, I think, of what integrative medicine is, regardless of what age you're looking at, is not about taking, instead of a drug, taking a supplement or improving your diet. It's really to say that, A, our priority is going to be try to use non-pharmacological, not surgical interventions first, if they're available and if they're evidenced. And second, that if we remove the block to healing of the patient, that will happen naturally, that our bodies are designed to get better. And the third, which is probably most important, that for chronic conditions, diagnosis is not the end point. And this is the point that I want you to take home. If you look at how current diseases are treated, you go to you have a symptom, you go to a physician, and you're told, okay, you have, let's say you have a joint pain. Okay, you have osteoarthritis, take this medication for pain, you're done. In integrative medicine, we think this way, okay, you have the diagnosis is a point of beginning, not the point of an end. Then we go in and we say, why do you have this problem? Is it because your kinetics or your load on a particular joint is off, and so you're overloading a joint? Or maybe you're not eating enough specific nutrients, and so there's an increase in inflammation. Or maybe you're eating certain nutrients that are causing inflammation. So you start just asking the question with diagnosis, and you never prescribe symptom management only. I mean, yes, we will definitely prescribe symptom management. You have to make people feel better, but you don't stop there. And I think that's the biggest difference from the way integrative practitioners practice versus sort of standard of care. And you can look at it this way, right? So before you drop into the medical aspects of care, we all have this core important organs and systems functioning base, like the roots of the tree, right? So if you're missing a big point there somewhere, and you're developing a disease of a branch, if you're a good botanist or you take care of the tree, for example, you're not going to simply cut the branch, right? You're going to try to figure out why that's happening. You're going to give the right nutrient, or maybe you will remove toxin. Maybe you will give more sun to a tree or whatnot, or connect them to other trees for a spiritual community. Yeah, anybody read there's this whole book about trees, all kind of, it's fascinating stuff. All right. Okay, so now the rest of the talk is very practical. I don't think you have to take notes. I presume is this recorded? So you can always come back, but if you want slides, David has slides and can share them with you. So most of the slides, if not all of them, are evidence. That's how I always talk. So you'll see if you want to double check something or just want to read the original, it's going to be at the bottom of each slide. So let's start with the acid suppressants. So if you're not comfortable, don't raise your hand, that's okay. But if you are comfortable, how many of you take the acid suppressants? 1, 2, 3. Okay, so the general expectations in your crowd, there should be at least 20 to 30%. So it's okay. If you're not comfortable, that's fine. Or maybe you just really have good docs, and they understand that this med's a double-edged sword. So proton pump inhibitors, things like omeprazole, things like Protonix, things like Nexium. So those are the acid suppressant medications that are often given for acid reflux, for ulcers, for lots of different intestinal problems. No, no. And also Pepcid or famotidine and all that older class, that's not part of that. The PPIs or proton pump inhibitors, those are the ones I mentioned, omeprazole, Protonix, Nexium, etc. Pantoprazole, that's Protonix. So they're very effective. They have very few side effects if you take them for a few weeks or a few months. The problem is they're often not stopped, and people just take them for a long time, and then you have all these problems. You have increased risk of kidney failure and infections, and now there's a concern of increased risk of Alzheimer's disease for people who take this drug. So, all kinds of things that are happening as a result, especially when you take it long term. So can we do better? So here's the example. So don't read the entire case. So older man who came to me because he was very fatigued and he didn't want to come. His wife dragged him in. But we connected. He's a long distance runner, and it's actually quite upsetting for him that he cannot longer run half marathon because he's so fatigued. So he takes the Nexium, which is one of the pills. So what can we do for him? Well, so this is an actual protocol. Protocol is in the book. So, by the way, if you're, as was pointed out, so if you're interested in getting some books after the talk, we have some copies. So the protocol is this. So we're trying to decrease the dose, and eventually discontinue, and then add some substitution. And it takes a couple of weeks to do that. If you've ever been on one of those drugs and then you stopped abruptly, many people have a lot of acid. Like suddenly they have a lot of stomach pain, they feel very acidic. That's because your body has been compensating. And if you stop the pill, the body is producing extra acid. So you have to sort of support that and wait for the body to stop making such an excess. And so really, this is some of my favorite nutrients that I give a lot of my patients with acid reflux, whether they take these medications or not. So aloe and okra you can eat as a food or drink in case of aloe. You can just buy this in any supermarket. And DGL you have to get as a supplement. Usually we give them as a chews. So people chew them as a candy after meals. Very nice and sweet, unless you really hate licorice taste. And they tend to work really well. All these approaches, they're basically coating your stomach. They're not affecting production of acid, they're just protecting you from that extra acid so you can feel okay while body recalibrates production of acid. So anyway, the whole point of this case, we did all of this for him. We also cut out on some of his coffee intake. Coffee is very acidic. And then added some minerals, and basically he got off of all the medications, all the blood pressure pills. So the point of this case for students is often you start cascading. You take one drug, and then you're going to start having side effects from the drug. Guess what the standard of care will do? They'll prescribe more drugs for that. So he started losing magnesium. He developed hypertension because magnesium controls blood pressure. So then instead of replacing magnesium, he got put on the blood pressure pills. And one of the blood pressure pills is a water pill, hydrochlorothiazide. So now he also peeing even more electrolytes out. Now he's even more fatigued because of that. Now it's even more hard for him to run, and he gets cramps when he's running. So that's a very typical cascading. So this is uncascading. This is kind of getting off of everything. So, okay. So who's here taking statins? Okay. All right. Now I expected that. Yeah, I know. But you're also taking CoQ10. Okay. So who's here of those of you who are taking statins, who's taking CoQ10? All right. So this is very for you. Those of you who raised the hand about statins and did not raise the hand about CoQ10, please listen carefully. Wake up if you're napping after dinner, after lunch. So I presume most of you are over 75. If you're not, this applies less. But so the data on statins for primary and secondary prevention of heart disease is extremely good, except when you get to 75. And past 75, that data starts to become very murky. And the reason for that is very simple. If you made it to 75 with no heart disease, chances are you're never going to get it. And so being on a statin suddenly does not give you as much of a benefit, because you statin and no statin, you'll probably be fine. But you start getting more side effects. And unfortunately, the biggest problem with statins, and by the way, this is, see the reference? This is American College of Cardiology, so it's not me saying this, or it's not from my book. And so American College of Cardiology is saying, past 75, you have to be super careful giving anybody a statin for any reason because of this. And this is this. So basically, yes, there is a 25% reduction in the risk of heart disease, but at what cost? And the cost of having progressive muscle weakness and pain is actually huge. Anybody who is into the field of longevity and healthy aging knows that the way that's going to determine how long you live is three things primarily, right? So one is sort of your engagement in life. Are you engaged enough? Are you waking up every morning and you're saying, okay, I got to do things, right? So that's one. Two is your social contentment or your social engagement. Do you have enough support? And do you need that support? Some loners don't need it, so they don't need it. That's fine. And the third is the muscle strength. And not what you eat, not your diseases. Even if you have a cancer, that's actually not a determinant. It's the muscle strength. If you're maintaining the muscle strength and muscle mass, that is much more important aspect. That's what we teach all of our fellows, by the way. People always forget, so we make them learn functional tests, such as wrist strength, the grip strength, speed of walking 100 feet, the way you get up from the chair and how quickly can you initiate the movement. So those are some of the very simple ways we can, as physicians, assess your capacity to move. That translates to probably, or accurately, how your muscles work. That is the more important than many other factors. Unfortunately, statins increase muscle loss. And there's nothing can be done about it. The idea that you can take CoQ10, and by the way, the reason that's happening, statins are mitochondrial suppressants, so they decrease the amount of energy produced, and unfortunately that affects the most the strength of the muscles. So this is from a very good Journal of American Heart Association. So there's been a very large analysis of looking at trials. If you give somebody CoQ10, are you going to improve muscle weakness, muscle pain, and muscle tiredness? And the answer is to some degree. Not dramatically, but it will work partially. So if you're taking statin, you have to take CoQ10. Here's the practical point. When you take statins, take a biologically, when you're taking CoQ10, make sure you're taking biologically active form of CoQ10 called ubiquinol. It's right here on the slide. I don't have a pointer. Well, you can see it. It's right there. It says ubiquinol biologically active. That's the form you want to take. You want to take between 100 to 200 milligrams per day. Okay. Trusted brands. We don't have time to talk about that, but you can ask David. He knows. He's not listening. All right, good. All right. Okay, so let's switch to chronic pain. I love this part because finally there is a major shift. If there's any silver lining from opioid crisis is that finally government started realizing we have to have non-pharmacological pain treatments covered by insurances. So that's what I'm going to talk about. But essence, some of these techniques integrative medicine providers have been using for decades. Massage, acupuncture, chiropractic, all those things are effective to some degree. So the acupuncture, well, actually, I'm going to skip this. So Medicare is now covering acupuncture as of 2019. Okay, that's a good news. The bad news is everything else. It's how that's actually implemented. So they only cover up to 20 sessions a year. Unfortunately, for people over 65, you probably should be getting acupuncture weekly, if not twice a week. That is at least 50 sessions a year. So it's grossly not enough. B, they only cover back pain. Well, what if you have a shoulder pain or neck pain? Okay, not covered. And C, it's even worse. The documentation is so draconian, and it has to be done by a physician, which is insane. Because why would I do this if I have an acupuncturist in my practice? Of course, they're more experienced in doing acupuncture if that's all they do. So there's a lot of hoops. So if you go around DMV and ask, your acupuncturist, do you take Medicare? You're not going to find much of anybody because of this, because it's so convoluted. They don't pay enough. They actually pay $47 per session. I don't know about you, but my plumber charges way more than that. And so I feel a little upset, correctly so, if the Medicare pays me less than the plumber. I think I did a little more education than that, but sure.
I have an acupuncturist who's a Chinese doctor who takes Medicare.
Okay, so everybody after the meeting, run to her, not to my table for the books.
Repeat the question.
I don't know. So maybe some people can make a living off of that, but I will tell you that most of our office is in DC or somewhere in Maryland. Ah, okay, makes a big difference. So Maryland has an additional copay. So Maryland pays a bit more than DC. They have like an additional, I don't know what that, but it's like an add-on. And also, of course, his rent is much cheaper than my rent downtown DC. It makes a difference.
The Zoom audience, would you repeat what you said about the doctor?
The point was that, what's your name? So Athy said that her acupuncturist, who's a Chinese woman, and she is in Rockville and she takes Medicare. So I said after the talk, everybody should talk to you to get that contact information. I hope she can take a lot more new patients. She wants patients. Okay, good. All right. Okay, so let me show you a case. It's a very instructive case. So this was a woman I saw with one of my fellows inside the hospital. How am I doing on time? Okay, I think we're okay. Yeah. So she presented with a very severe complication of toxicity from this drug called gabapentin or Neurontin. Anybody here takes this drug? A couple of people, yeah. So, if you don't have kidney problems, don't worry. You're not going to get this type of a problem. But this patient had a kidney failure, and they increased the dose, and they overdosed it very rapidly. So patient was in intensive care. We treated her successfully, got her off the pill, but guess what? Her pain came back. So now she's asking me, what am I going to do? So this is a very typical approach that I would do as of about 10 years ago. Now there's a major difference in how I do business. You'll see it in a minute. But this is what we would do. Notice none of them are medications. These are all supplements, biofeedback, acupuncture, and the medical cannabis. And so this woman at age of 85 tried all these things and said absolutely no to everything, absolutely yes to cannabis, best thing ever. My pain is completely controlled. It costs me a fraction of copay for gabapentin. I'm never going back. And by the way, this is a long time ago. And then she said, and by the way, my primary care wants to put me on a new drug because she says the cannabis is going to kill me. I said, okay, hold on, let me call you to your doctor. So we had to do some education. Now this doctor sends me a whole bunch of patients. So that's that. The whole mudslide of older adults using cannabis started about 10 years ago. By the 2016, as you see, it's the fastest growing users of cannabis in the United States of America. Well, it just simply says that everybody else has been using it already. But you see, that's the fastest growth. It's from 0.4% to 2.9%. So it's really fast. And the reality is, so this is from Israel's study that has now been replicated in a smaller scale here in US, and you see the dramatic effectiveness. So you're talking about 90% of patients going to be very happy after the treatment. So this was 200 some patients, and you can see that out of everybody who was taking it, basically only 12 patients here said there was no effect, and 250 said it was the best thing ever. It was 10 out of 10 response. So, basically very effective. Now, there are side effects. Luckily, there's no really terrible side effects. And the real side effects are the logistics, not even the cost. Cost is getting better, but logistics are horrible. And each state does it differently. Virginia is a total, dark ages, and I don't know if they're ever going to come out of those dark ages, but Maryland trying to make it a little bit better. DC just removed all the barriers, so you don't even have to go get a physician's approval. You just walk in and they give you a card. But it's still the fact that it's not federally legalized, everything is convoluted. So it gotten to a point where I saw so many good responses that quite recently, one of my medical students who just graduated a few months ago, Kimia, we decided to publish this case. And basically what I want to highlight, this poor woman has been suffering from back pain for over 10 years, 5 MRIs, multiple orthopedic appointments, couple of surgeries. In essence, all we did for her, and I want to skip all this in a matter of time, but really just to concentrate, that's what we did. We gave her some B vitamins, fatty acids, magnesium, cannabis, and then she was doing massage and acupuncture. That's all she did. And here's what I want to show you. So prior to seeing us, healthcare dollars spent on this woman in 10 years, $500,000. After she joined our program and she's now completely pain-free or controlled, she's not free, pain-free, she has to take what we give her, $6,000 a year. So this is 10 times cheaper than a standard of care with much better outcomes. Okay, so I just want to show you this case more as an unfortunate reality of how expensive and ineffective this is. The cannabis for insomnia, very, very effective. I'm not going to cover this in a great detail in a matter of time because I want to come to the last point, which is this. So the Alzheimer's disease is the fastest growing epidemic of the world. It's by far the most expensive disease in the United States of America. It's more expensive than cancer and cardiovascular disease combined. And it will get worse rapidly, right? Because it's the very fast growing incidence of Alzheimer's. The current treatments are suboptimal, but if you look at some of the leading experts, this is from Lancet Commission, which is kind of like a European version of JAMA, Journal of the American Medical Association. They're basically saying more than a third of all the cases of dementia should not occur because we have all the means to prevent them or treat them very early. But yet, everybody knows what happens in real life. People get put on medications and nobody talk about anything else when you come to the Alzheimer's. And this is now what I do. About half of my time in clinical practice goes to this one condition because of how effective our approach is. And we know all these risk factors. We knew about them for many, many, many decades, for like 100 years roughly. And yet, when you go to a neurologist, they will never talk to you about toxicity from something, or sleep apnea, or, well, sleep apnea they may, or inflammation. So they're just not going to talk about it. They're going to give you a medication and they're going to follow you. And the reality is, if you do all of that, what you can achieve, as I'm about to show you, it was pioneered by this organization, and the brain, the head brain of this organization is Dale Bredesen. It's called Bredesen Protocol. And this is the first 100 cases published in 2018 of a complete reversal of Alzheimer's disease. There is 3 patients from our clinic. All 3 are still completely reversed. One of them is my own father, who was diagnosed in early 70s. He's 87 now. He's still completely functional. He has some memory deficit and he's slow at some processing, but he's not taking any medications. He still does everything. He drives, shops, does all the maths, everything, runs finances of the house. And the protocol is very complicated, but each aspect of the protocol addresses specific risk and specific individual driver. Because each patient with Alzheimer's is going to have gazillion different drivers. They're not going to just have plaques and tangles. Totally wrong idea. Plaques and tangles, protective mechanism of the brain, removing toxins from exposure. They're not bad necessarily. What's bad is what's causing them. And you have to address the cause. And when you address the cause, instead of looking at the medical aspect of it, you have to look at the non-medical aspect. The removal of toxicity from someone's environment has nothing to do with medicine. If they have mold in the house, you have to remove the mold. That's about half of all the houses, roughly. Luckily, since it's the toxicity individually is much lower risk, it's like 10%. But if you have a mercury in your teeth, well, you have to remove those, right? At the lunch, I was mentioning that my whole path to integrative medicine started with my own health in my 20s. I grew up in Russia, no fluorination of the water. I never had a good teeth hygiene to begin with. I had 14 silver fillings by the time I was 14. So in my early 20s, I was so mercury poisoned, I developed asthma, I developed dog allergies and cat allergies, and so I couldn't go to vet school. So me standing for you here, you should congratulate Soviet Union for putting all the shit in my mouth, pardon my French. So then I had to drill them all out and deal with all the detox. Took many, many years. But anyway, I'm better now. So, and this is the summary of the trial. This has just been published less than a year ago. And 84% of patients with Alzheimer's improved. And they improved from mild Alzheimer's to no Alzheimer's, basically. So the Alzheimer's resolved. Now, if you take the protocol away, the people will get worse. It's not a cure. The drivers are not fully eliminate it most of the time. We can work with them, but we sometimes just cannot fully eliminate them. Mercury can be removed, but if somebody is very sensitive to sugar and they're still eating it, they're going to be sensitive to it. There's not much I can do to sort of just change them so much that they can then eat whatever the sugar they want. So some of these factors are lifelong. And this is our data. So we have significant percentage. So at this point, we saw 61 patients. Half of them cannot stick with the program. It's not covered by insurance. It's very expensive. If you have to replace your silver fillings, it's going to be tens of thousands of dollars. If you have to have implants or crowns, it's expensive. So a lot of people simply can't afford it, or they can't maintain it. It's very complex. You have to have a very good team around you. In the trial, the team was provided at no cost. Right now, none of this is covered, so you have to pay for all of that. That's not so simple. And this is some of the selective cases. So this is 91-year-old, we reversed him. And he was eating swordfish, so don't eat swordfish. Eat your salmon or sardines, but don't eat. Swordfish is horrible. It's like 10 times more mercury than tuna or something. It's like really bad. Tuna is bad, but that's even worse. And this is a very typical case. A 75-year-old woman presented with a mild to moderate Alzheimer's. She has this feared ApoE4. Despite that, she's doing completely better. So she still has a little bit of deficit, but her score, which is 26 out of 30, is now considered normal. So she still reads. She wasn't reading when she came to us. Now she reads. Doesn't drive, but she reads. And this is now 3 years later after she starts seeing us. And the case that I was talking about, swordfish, we actually published this because it was so dramatic that I decided to publish this case. So, and there's some other points here. We use a lot of neurostimulation, like we use natural 40 hertz light through the apps on the phone. So, but anyway, this is the paper we just published about it. And I'm going to stop here and put this slide on, and let's do questions.